we'll go ahead and get started now. I am really excited this time to be able to introduce our speaker, Dr. Notarianni, on a topic which I think is receiving more and more press. It's becoming, obviously we all know the Major League Football is looking at this, military is looking at this very strongly. Nevertheless, I was looking at TV the other day and I saw an advertisement for a program where they get 8-year-olds out with helmets encouraged by large adult males to kill each other. So, I don't know, have you seen that one?
No, there's plenty of them though.
Anyway, Christine.
Okay.
Thanks.
Well, thank you all for having me. We'll go over some things that probably you're familiar with and some things you're probably not. We'll start off with this is a lighthearted talk. If you want to interrupt me, that's fine. I don't mind. But we're going to kind of go through the gamut of what concussion is. So concussion is a traumatic brain injury. So for many, 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 many years, people just thought it was nothing. It was a minor head injury. They didn't consider it as true traumatic brain injury. Most of the time as we go through this, you'll find that they do not have a loss of consciousness. In recognition over the past 10 years, that's really been the driver for management of concussion and furthering the field in concussion. We're going to talk a lot about concussion in sports because that's where most of the research is done. We'll touch a little bit on the military as well. But that's where everyone's focus is right now, especially here in the United States, parents, NFL, all that kind of stuff. And when you think about TBI just in general, it's a really big increasing public health issue. And the WHO predicts in 2020 that TBI is going to be one of the leading causes of death and morbidity of all ages. Right now, it is one of the leading causes of death and morbidity in adolescents, but they predict that that is going to greatly increase. Now, there's reported about 1 to 3 million concussions a year in the US, but that number is probably not real because we don't know how many people don't actually seek medical attention. So there's probably many, many more people who have concussion that we never even know about. And that adds up to about $60 billion in economic costs of treatment if you start thinking about all the ER visits and medical visits and all that kind of stuff. So it really is becoming a big public health issue. And so again, if you're thinking about it, we're talking about 3.5 million concussions a year. But really, only a very small minority is coming from sports. But this is where all our focus is. This is where all the research is being pushed through and people looking at better ways, safer ways to play. But really, that's not the main cause of concussion. You think about children, a lot of times it's just falls, falling off their bike, falling down, getting hit, getting in an accident, something like that. And so what happened 10 to 15 years ago? It was really what you would consider the perfect storm. So you had NFL players who were dying, either committing suicide or having these events where they are having these weird psychiatric events, having major concussions on the field where they're getting knocked out. You had high school students, 13 and 14-year-old students who died from an injury. Now, Zach Lysett, we'll talk about in a little bit, he did not die, but he had such a traumatic brain injury that it prompted legislation throughout the states. And then you had your military coming home from Iraq and Afghanistan and noting a huge amount of traumatic brain injury in these soldiers that really wasn't talked about before, and a lot of blast injuries. And so what happened was, most recently, the Brain Trauma Foundation has really led the coalition on this. And so the first thing they said is, we need a concrete definition of what a concussion is, because so many people have different ways of diagnosing a concussion and calling a concussion, that they wanted a very uniform way that is applied. Now it's applied by the NCAA and the NFL. So this is what they came up with, and this is their definition. A change in brain function following an external force, may have a temporary loss of consciousness, is identified in awake individuals, and has measures of neurologic and cognitive dysfunction. So this is your formal definition now of a concussion. And so we'll touch a little bit now on the military. So what we know from the military is that a large number of service members recently are coming back with TBI. And a lot of it is from blast exposures. So it's a little bit different TBI than when you're thinking about people or falling down or getting hit in the head in football. But this was relatively unexplored by the military. It's considered an invisible injury, TBI. It's hard to diagnose. People don't want to talk about it. So it really was kind of not discussed in the military in any great detail. But what we know from World War I is shell shock. And so when this definition came out, these soldiers were either in the trenches or coming home with these severe psychiatric manifestations. And so headaches, amnesia, difficulty sleeping, even committing suicide. And so at that time, it was not clear, is this a straight psychiatric condition, or is this the stress from the stress of combat, or is this a physical injury to the brain? Because these soldiers were taking huge amounts of mortars down in the trenches, and they're having to jump up over the hill and fight. And so there were wartime committees at that time, and they declared it to be psychiatric. It's a psychiatric injury. There was no actual evidence to support this in terms of, there were no pathological studies on brains of soldiers coming home with this who died. And some soldiers were actually executed for this, for having this disease. And this was an ad at that time. So it became diagnosed as shell shock, and your soldiers were coming home with this diagnosis. And there were many, many, quote, therapies out there to treat shell shock. One of them was basically ECT, like depression. So this was just an ad in one of the papers back then to treat a type of shell shock or psychiatric conditions. So unfortunately, what that means is that it transitioned into PTSD. So we saw it from World War II to World War I to World War II to Vietnam, and then and that kind of came out as PTSD, and that was the term, the diagnosis. And I'm not saying that PTSD is real. I completely believe that that is real. But now looking at the soldiers from Afghanistan and from Iraq, there's probably a much bigger overlap than we realize with PTSD and chronic traumatic encephalopathy and traumatic brain injury. So this was just a study done, and there's 3 models you can think of PTSD and then TBI. They can be completely separate, with a suicidal ideation completely separate, not related to either one. There can be a little bit of overlap based on the patient's suicidal or not, or there's a lot of overlap. CTE, TBI, PTSD, and that's probably the best representation that we have now, is that these are something along a spectrum. TBI, concussion, leading to PTSD, leading to CTE and probably PTSD. There's probably a blend of this together. And there's certainly some people who have straight PTSD as well. So what happens in a concussion? We don't know the exact specifics. What we kind of know is, okay, you get an impact. And so there's an acceleration, deceleration force in the brain. And then there's a rotational component to it. So it's not just the impact of the force, it's also the rotational and shearing aspect of the brain itself that's causing microscopic changes within the tissue. So this is a really busy slide, but basically what we're talking about is you have resting microglia, and when you have the hit and the impact, there's a disturbance in the potassium efflux, sodium influx, calcium rushes into the axonal cells, and that leads to further excitation. So what happens is these microglia get activated, they release lots of cytokines, they activate your astrocytes, and this leads to this activation cascade, which ultimately leads to cell death. And so then we are now looking at these different areas to try to target how can you diagnose a concussion? Can you look for things in tissue or in the serum or CSF to try to mitigate this? So there's a lot of, basically the whole synapse is disrupted, and this is still being investigated as to exactly what that pathway is and what's the best way to test for it. So a lot of people right now, the hot topic is looking at biomarkers. So can you look at blood or spinal fluid and tell if someone's had a concussion? And then can you track their recovery from a concussion using biomarkers? So this is where a lot of data is coming out of. There's not a good answer yet. So what we're talking about is, should you have a one-time or multiple samples? Like one time when you come into the ER? Should you get blood? Should you get spinal fluid? Not a lot of people, when they come in with a concussion, really want to have a spinal tap. Is the spinal tap going to be the same predictive CSF as what's going on in the brain itself? We know that the CSF's in communication, but at that time period, is that going to be effective enough? What about subconcussive events? So people get minor hits and they didn't really get a concussion. They don't have symptoms of a concussion, but you know that you see them. Oh wow, you got a hard hit, but they feel fine. They have no symptoms of it. What happens there? Is that compounding onto a concussion? Is that going to lead to further brain damage? And what is best to look at? We don't know. These are some of the top 3 that are being investigated right now. And so you can see this was a study that came out. They looked at no TBI, an uncomplicated TBI, which was basically their CAT scan was negative, and there was a little bit of a bump in S100, which kind of is a marker of blood-brain barrier disruption. And then in complicated TBI, you can see those markers went up again, and that's when someone had a head bleed or some contusion along with that on their CAT scan. And there you see a big bump in GFAP, which is a neuronal marker, which kind of makes sense if you've got a head bleed or some kind of obvious injury on a CAT scan. But there's not a good answer right now as to what a good biomarker is. Everyone is looking into that. There's probably over 50 clinical trials right now looking at different biomarkers. And then advanced imaging. So most people may or may not get a CAT scan. And if you do get a CAT scan, it's probably going to be normal. So what benefit is that for us? It's not helping us at all in diagnosing concussion, tracking their progress in their recovery, or possibly tracking their potential damage. So more advanced imaging obviously is coming along. So DTI, where we're looking at tractography and looking at your cortical spinal tracts and different things like that, that's coming along, as well as DWI and MR spec. So we use those methodologies here very frequently in neurosurgery. We use them to map out a tumor and look at where the cortical spinal tracts are and how they're pushed away. And looking at MR spectroscopy, we focus our little voxel on the tumor, so one small abnormality. But now you're talking about applying a spectroscopy and looking at the chemical milieu of the brain itself, but you're talking about applying it to a very wide area. So how are we going to interpret that? So it needs to be accessible and safe. It needs to be something that is equally sensitive across all your injury severities. It has to be equally sensitive through an acute and a chronic phase so that we can actually provide information to the patient and to be able to track their pathological changes. So this was a study. This was bold sequences here, and you're looking at activation. These were military personnel coming back from blast injuries, and so they've got activation of their cingulum and their prefrontal cortex that we're seeing that is abnormal after their injury. And then this one is looking at PET imaging. That's another one that's kind of coming down the field as a possibility, but PET is not easily accessible. You got to inject a dye, so probably not going to pan out well. But here's a control subject, and these are 4 different subjects from the NFL, and they see different areas of activation within their temporal lobes who all suffered from CTE. So we definitely can track it, but we don't know the best way and how to make it accessible for everyone. And hopefully people really want to be able to use this to where you might want to say, hey, your biomarkers are up, your scan is progressing, your imaging is progressing, and maybe it's time for you to retire. So trying to give people more information as to how bad their brain injury is going. So we'll talk a little, this is very familiar to all of y'all, but diagnosis and management. Everyone knows this, all the medical students know this, okay? Recognition, right? This is all the things people come off the field with, and you're going to take the player out of the game. That's easy, okay? Get them out. You're going to do a sideline exam. There are thousands of sideline exams. NFL and CDC have some great ones. They can be very short. They can be pretty extensive. So this is the NFL one. Okay, I blew up the top part of here just to show you, but it's 2 pages long. I mean, it's looking at all kinds of different things. Do they know where they are, and they're oriented and things like that. But then these are automatic no-goes. So they had a loss of consciousness. They're confused. They have any kind of amnesia, any new symptoms or persistent symptoms like they're dizzy, or any kind of abnormal or neurological finding, obviously, because you're worried about a cervical spine injury or something like that. So, but you can see what they're tracking. What was their mechanism of injury? Was there a penalty call? Was it at practice or during the game? All of that seems to have, we're all kind of looking at those different parameters because the hit that you get in practice may be a lot different than the hit that you're getting in a game. So this is just an example of one of these, and you can get them all over the internet and off the CDC. And they have marketed these out now for high school athletes so that you have your trainers on the sidelines who can do this quick sideline exam for your athlete. So one of the issues I have with sideline testing is the NFL has been a big proponent in this, and they've done a great job in really pushing recognition of a concussion. But you think about, they have like expert trainers, okay, and they are skilled in looking at these players. But then you get to the high school and you've got maybe a volunteer physician or a parent on the sideline that's doing these examinations, and maybe they don't understand exactly what to be looking for. And so one of the problems is, what's the first thing they ask when they get pulled out? They say, "Are you okay?" That's probably the wrong question to ask, right? The player's confused, they don't know where they are. They're going to just reflexively say yes. Yeah, I'm okay, because they want to go back in the game, they care about their team. So probably the better thing to start with is what's called the Maddox questions. So these are the questions that you would ask. What game are we at today? What quarter is it? Who scored last? Who did you play last week? And did your team win the last game? Because these actually require thought and concentration. So you get a much better feel for how confused or disoriented the person might be. So again, how do you know? This is pretty common knowledge, things that you can have with a concussion. Most of the time it's going to be headache, dizziness, they're a little bit off balance. Only 10% will have a loss of consciousness, so that does not, if they don't get knocked out, it doesn't mean they don't have a concussion. This is just another study that just kind of showed some things, because I think people forget some of the emotional components of a concussion, being irritable or depressed or emotional, that can be actually a sign of concussion. So I think that's really the important thing to stress, is that it's not always just headache and nausea. So do you need to image? Probably not. I mean, if a person's completely wide awake and says, my head hurts and I'm dizzy, you probably don't need to. If they go to the ER, a lot of times they're going to get a scan. And they're looking for bad things. They're looking for a hemorrhage or contusion, and most of the time it's normal. And an MRI is always a good test to look at, but it's not something you're going to use in an acute phase unless there's a true deficit or something you can't see on a CAT scan that you're concerned about. But usually we'll do that later. So a few weeks down the road or a month, if they're still symptomatic, that's when we're going to do an MRI. This was actually the most recent guidelines from the American Academy of Emergency Physicians over TBI. So there's no evidence for an MRI or CT. And a CT with a loss of, you only need to do a CT, is their recommendation, if they've had a loss of consciousness or they have amnesia. Now you can consider it if they have no loss of consciousness, depending on their symptoms. And they define that as older patients over 65, if they've got very severe headache, very, very severe headaches, vomiting, any kind of focal deficit, obviously, or a GCS less than 15. So you could if you needed to, but they're also saying you don't have to if they fall up in the other category. And anyone who has a mild TBI can go home. They have a negative scan. They don't need to stay overnight. And you'd provide them with instructions on post-concussive syndrome, and explain to them, what you need to look for and what you need to come back for. So then, when someone leaves the ER, that's when coming to your primary care or coming to me or a neurologist is going to come into effect. So this is when we use more testing to really frame the overall neurological deficits of the concussion. And these are neurocognitive and balance. Again, the sideline test can assess this. King DeVick is an eye movement test that you can do on the sidelines. You can also do in your office. But there are more computerized neurocognitive tests that you can do in your office. So impact testing is one that I have. It takes a 20-minute test, and they just sit in a quiet room, and they have all different visual-spatial tests that they go through on the computer, and then it gives you a report. The best thing, though, is to have this before you have a concussion, and then have it again after you've had the concussion, and then track your recovery of that patient. Most recently, eye tracking has been a really hot topic if you're looking at concussion research and what people are trying to figure out and what's the best thing to test in concussion recovery. So eye tracking and predictive timing measures how well they're paying attention. And so when you have delayed reaction times, delayed smooth pursuit, there's an effect on their concentration, and we can tell that. So the issue that you run into is that if you maybe answer all the questions correctly, but you're having some issues tracking, you're going to have possibly an increased risk of injury if you go back in the game or practice, because your reaction times are slowed. And that's what they're picking up with these eye tracking. And so you can keep someone out of the game because you're picking this up. This is a study going on right now. This was funded by the Department of Defense in 2014. This is this eye track advance. This study is enrolling 10,000 subjects. They are looking at 5,000 athletes, 5,000 military subjects, and then some normal subjects. And they're collecting data on eye tracking in the normal subgroup, and then in the concussed athletes and the military. And so they want to be able to compare those normal to baseline so that we have a really wide spectrum to know what could possibly be going on when you're getting concussed. And so this has some data from them. So this is normal. So the left eye and the right eye are following a dot in a circle, and it's nice and smooth. They're following a dot across. It doesn't project well, but there's a little dotted line. They're following the dot across the dotted line, and their eye is directly lined up with that dot at all times. This is right after they get concussed. And you can see their smooth pursuit and their tracking is significantly altered, and their eye tracking is significantly altered from the dot itself. And then if you look at someone who never had a concussion, and then they get concussed, and this is their exam, and then I think this is about 4 days later, they recover. So it is something that we can track and see the recovery from. So this is where a lot of people are really looking into this now to look at your concussion management. So they're out. Now what do you do? So rest. We all know that. Initially, it was really pushed for prolonged cognitive rest. And now there's a twist to that that's really pushing for active rehabilitation. And all in all, 80% are going to recover in 10 to 14 days. They're going to be fine. But some of them will take a slight bit longer to recover. And why is rest important? Well, as I showed you earlier, there's a huge activation going on at a cellular level that we can't see on an image. That is going on in the brain. And so you're trying to let that calm down before they get impacted again and something else happens. And there's a lot of animal studies that show that these receptors and excitation get way out of proportion, and then that leads to neuronal cell death. So right now people are really starting to push active rehab. So we used to say you had to be completely symptom-free before you even start any kind of physical activity, and you totally isolated that athlete. So they, in the NCAA, they were not allowed to go even to the coaches' meetings. They weren't allowed to watch film. They could not participate at any level. They had to have complete cognitive rest and physical rest. But now people are starting to advocate if you have symptoms beyond a few days, it's probably better to start some light activity while you're still mildly symptomatic. Maybe you still have a little headache or a little bit of dizziness. And then really focus on your rehab for your appropriate dysfunction. So if you've got dizziness or visual symptoms, and really working one-on-one with someone for that. And so that's where the newer kind of concussion literature is really pushing to get people involved earlier. Which is better, we don't know. Honestly, we don't know. Everyone's speculating. So there's nothing to support either method, prolonged rest or active rehab. We really don't know. So in general, when can they go back? You'll say symptom-free for 24 hours and then gradually increase. Now, if they've had symptoms for a few days, you may start some light rehab, like just walking on a treadmill, not even raising their heart rate. And then as they progress, you're going to slowly progress them up through physical activity back to normal. In general, most physicians are not going to clear someone until the next season, or maybe never at all, depending on how bad off they are. But if you've had 3 concussions in one season, for me, you're out. That's it. And if you've had 2 really bad ones, you might knock them out. But this is all anecdotal, and it really depends on the physician. So there's a lot of doctor shopping. If that player really wants to play and he doesn't like what you say, he's going to go around and try to find the right answer. So this is just kind of a table just showing you how to rehab your patient. Just general guidelines. No activity, light activity, just walking or on a stationary bike, but you're not raising your heart rate. And then sport-specific, non-contact drills, full contact, return to play. So what are some risk factors for concussion? People are looking into this now. They want to know, how can I be safe? Previous concussion is number one. If you've had a concussion before and you've had post-concussive symptoms for more than a week, you're 2 times more likely to have another concussion. Female athletes, when you look comparatively across sports, have a higher rate of concussion. And that's probably because they've increased head acceleration during impact when they look at soccer players, so they think that their neck muscles are probably a little bit weaker than their male counterparts. And females tend to have a more willingness to report the concussion. So they're more likely to tell somebody, I don't feel good, something's not right. When you look at age versus young age versus an older age child, that kind of has contrasting findings, so there's not really any data there. Genetics has been relatively limited. Most of the literature is focused on the ApoE gene. This is a neuroprotective gene, and so when people have a deletion of this allele, they seem to be more susceptible to concussion. This is also being investigated heavily through CT, so we'll talk about that in a second. Behavior. So if you have a more aggressive player who just gets out there and just goes for it, are they going to be more likely to get concussions? And that's not really well defined. A game versus practice. Obviously, it makes sense that it's probably higher in games. The adrenaline's up, you're excited, you're going to really, you're going for it. So there's more contact there. The mechanism of injury, nothing has determined a risk estimate. So if you get head-to-head or head to the ground, how that impacts you. But your playing position does seem to impact you in terms of football. The quarterback and the wide receiver seem to have a much higher increase of concussion, and probably just because they have a lot more contact. People are coming after them with the ball. Your playing level is not consistent. So as a high school athlete who's less skilled and doesn't understand rules of safe play, more likely to get a concussion than maybe an NFL player. Again, that's not consistent. And protective equipment actually trends you for an increased concussion. And that's probably because people think, I've got the helmet on, I got the pads on, I'm protected, and I'm going to go for it. And so it actually has made things a little bit worse in that realm. So why are we so worried? We had this huge storm of events happening, kids dying on the field, athletes taking their own life. And this is one of the big stories that came out that really pushed forward a lot of concussion research in the past 10 years or so, 10, 15 years. This is Zach Lystad and his second impact syndrome. So he was a 13-year-old football player, and he was playing in the game, and he gets hit. And I'll show this short beginning part of this video and see if it works now.
When he was 13, Zachary Lystad, Maple Valley, Washington, near Seattle, loved to play football as much as his dad, Victor.
Zach never shied away from going after the ball carrier.
So this is the play that actually affected the rest of his life. So he gets hit, tackles the player, he gets hit, and then he falls down and hits the ground. And they cut away, but what happens is he's laying there like this for a few minutes on the ground, gripping his head. And then it was halftime. So we went to the locker room. Came back, played the third, fourth quarter, and then I'm trying to turn the volume up. But
when Zach collapsed, and the Lystad family's nightmare began.
He's like, "Oh, Dad, my head hurts. It hurts real bad."
I'll try to turn the volume up for you, but
What's up? And then it progressively got worse. When he collapsed, he did, "Daddy, don't let me down. Don't lay me down. Dad, my head's killing me." That's the last thing I remember him saying, for 9 months.
A comatose Zach was airlifted to Seattle's Harborview Medical Center.
He was minutes, maybe an hour away from dying. He had a bleed on the right and the left side of the brain that was compressing his brain, and that required them not only to take off the bone each side of his brain and leave it out, but actually take out the blood clot.
When you looked into his eyes, he wasn't there.
so it took him 9 months to speak, and it took him over 5 years. I think. Sorry, I'm trying to turn this down. Okay, 3 to 5 years before he really walked. I think 3 years, 3.5 years before he walked. So this was a really traumatic event in Seattle, and that has led to. Go. Okay, the Zach Lystad law. So this started in Washington State. This is from his actual event. And so this is what has been enacted across the United States. And if a player shows a concussion, they have to be removed. And they cannot return until they've been cleared by a professional. And this was enacted in Louisiana in 2011. So what they're talking about is second impact syndrome. And this is what really scares people. This is a catastrophic event, although it's extremely rare. Everything that we know about it is based on case reports. There's no real substantial data to make any definitive statements. We know that your impact results in an increased cerebral blood volume. There's some failure of autoregulation, and so you're getting cerebral edema. And so then you have raised ICP, and then you have eventually herniation if it's not treated. But many people don't know, do you even need that second hit for this to occur, or would it have progressed beyond without it, just because you had such a severe increase in intracranial pressure? We don't know the risk factors for it. It obviously seems to affect younger children. And if you have post-concussive symptoms, you're more likely to see this occur, which is why we've been so proactive now in pulling children out of the game. The cognitive deficits, obviously, like we talked about before, you have a delayed reaction time. So if you're put back in the game, you see that guy running at you, you're not processing at the normal speed. And so you don't get out of the way, or you take a bad hit, or you fall hard. And so then you lead to another severe injury. And we know that that concussed head is opening a window. Your brain is vulnerable, and we know there's impairment in metabolism, and these can persist. So there's something going on that we cannot figure out. But this is what everyone is really, really worried about when you're talking about your child playing football. And now you're talking about what's the permanent deficit that we're looking at. You think about all the stuff that comes out between CTE and the NFL. The NFL settled a major lawsuit for concussed players. And so CTE is not really a new term. It's new in that now we're talking about it more. But it was described back in 1928, and that was with all the boxers, and it was called dementia pugilistica. And they thought it was because of repetitive, often minor head trauma. These boxers are getting hit. And so it initially manifests as disturbances, affective disturbances, emotional lability, short-term memory loss, and then it progresses onto dementia. So you'll see them having increasingly erratic behavior, speech and gait difficulties, and then full-on dementia, depression. And there have been a number of football players who have taken their own life because of this disease. And a lot of them now, are taking their own lives and purposely not shooting themselves in the head and shooting themselves in the chest so that they can preserve their brain to be studied, because there's been so much out about it now. But it's not limited to professional athletes. So there's a huge CTE foundation through Boston University, and they have found CTE in a small number of athletes who never played sports beyond high school. They didn't play in college, so we don't know, is it the type of hit to your head, or is it the number of hits to your head? Does subconcussive events play a role in this? They don't know. So there's a lot to be investigated in this area. We do know that the symptoms present many, many years later. So it's hard to track some of these people. You don't know. It starts with memory loss, confusion, impaired judgment, depression, suicide. And again, the diagnosis can only be made post-mortem. So you're diagnosing these people after they've already gone through all this. And what we see when they examine the brains of these athletes is there's progressive degeneration of the brain tissue. There's a tau protein that's diffusely deposited throughout the brain, but it seems to prefer the limbic system. So it kind of accounts for your psychiatric disturbances and your depression and aggression. And so this is a normal subject. And this is just showing the tau protein deposited within, this is actually the temporal lobe. So this is where a lot of the research is going. The tau protein is histologically identical to what we see in Alzheimer's disease. A little bit different in that beta amyloid is not really seen in CTE. We do see it in Alzheimer's. And the location of where the tau protein is located within the layers of the brain is different than in Alzheimer's. But Alzheimer's, TBI, and now CTE all have an increased prevalence for these ApoE allele deletions. So there's something going on with their neuronal protection in these athletes and patients. It's not exactly the same disease as Alzheimer's. We know that. It's the same protein, but it's not exactly the same. Their symptoms are presenting differently. Your Alzheimer's patients are presenting later in life. They're in their 60s. And they're mostly having memory problems. Depression and anxiety and aggression is not prevalent in Alzheimer's until very, very late when they're extremely demented. But in CTE, it starts with aggression, judgment issues, okay? And then it progresses to more of that memory problems and suicide. And their brains look very similar when you look at them histologically, just grossly. This is an Alzheimer's patient. This is a CTE patient. They kind of have a shrunken frontotemporal regions, just similar to an Alzheimer's patient. And then the other thing that's coming out with CTE is that there seems to be some association with ALS. So there have been 3 athletes with CTE who also were found to have motor neuron disease. And this was looking at this tau protein TDP43, and they're seeing axonal loss just like you would in ALS in a CTE patient. We know that these tau proteins are widely expressed throughout the brain, but their function is unknown. And when they're overexpressed, that seems to be the problem. There is neurodegeneration and cell death with that. So this is another area that is coming down the pipeline that people are really getting concerned about and trying to diagnose neurodegenerative diseases. So what we're thinking about is that mild TBI causes some kind of shearing. We know that, and there's a cytoskeleton disruption. And what happens is the neurofilaments in the brain reorganize, and then TD43 is upregulated. This tau protein is upregulated, and it binds to the messenger RNA to stabilize the process. But what happens is it causes an overregulation, and then there's protein aggregation, neurofibrillary tangles, neuronal cell death, and that's what's leading to their progressive disease. And now we're seeing it in younger athletes. So it's not just someone who's been playing in the NFL for 30 years. The NFL looked in 2009 at 1,000 retired athletes. 6%, 50 and older, had dementia-related diagnoses, and this was 5 times higher than the national average. But what's more concerning is that almost 2% of 30 to 49-year-olds had dementia-related diagnosis, which is 19 times higher than the national average. So something is going on. And if you think about it, there are more than 1 million teenagers competing in football every year. And so CTE has a potential risk of being a public health disaster. The NFL has been very good at putting a lot of money into concussion research and things like that. They're kind of forced to, but they've done a really good job at that. So I mean, this is what people are worried about every day. Almost every day you see articles like this online in the paper. How do we keep people safe? What's concussions looking like? So, and everyone in every field of medicine is getting asked these questions. So how do you not get a concussion? Well, there's prevention, there's awareness, safe play, proper fitting gear, awareness. This is where everything has been targeting so far, right? Everyone is out there, making your players aware, making the parents aware, making the coaches aware, and recognize it not only in you, but maybe your teammate, and pointing it out to somebody, not hiding your symptoms, and trying to express to them that it's better to sit out one game than an entire season, or permanently. And so this is from the CDC. They have these for high school athletes and for middle school athletes, and these are up in the locker rooms, and they actually give out forms to the families every year when they're signing up. And just to remind them of what a concussion is and how do you diagnose it and what happens. So trying to protect their brain. The NFL and the NCAA have been great at instituting new rules to try to mandate safer play for your athletes. So the NCAA now has in-season, post-season, preseason rules as to the practice schedule. So it limits contact practices and mandates days off. So when they're in season, they can only have 3 days of non-contact, 1 day of what they call live contact or tackling, and 1 day of contact or thud tackling. So it really limits their hits that they're getting and trying to mitigate that. We know that they're getting fined now in the NFL for head-to-head hits. That's probably a good thing. And then no spear tackling, which is helpful for concussion and also for cervical spine injury and catastrophic quadriplegia. And they've moved up the kicking off start point, right, so that you have more touchbacks, so they don't have that just head-to-head running down the field full speed and colliding into each other. And then USA Football is actually starting a pilot program this summer or this fall, and they have made some changes to some of the youth football programs to study that and see if it helps. So they've cut the playing field from 100 to 40 yards. They only have fewer players, only 7 on each side. No special teams, so they cut down on open field hits. No three-point stance, so the defensive players that get down to three-point stance and they just jump up and they automatically are leading with their head. They're cutting that out. And then they're telling that all the players have to rotate positions so that you're kind of rotating their chance of getting impacted and trying to match up players of equal size to see if that has an effect. And then now that better technology is coming down the way, so everyone thinks that we can make a better helmet, a better mouth guard, better something. Nothing is 100%, and nothing is going to completely protect you from getting a concussion. But this new helmet that's being marketed, I think they're using it at Virginia Tech right now, has this 4-layered helmet, and it's custom fit to the player based on their head circumference and everything like that, and not just here a one-size-fits-all helmet. And it has this outer shell which actually deforms when you get hit, kind of like a bumper of a car. And then it has an inner layer called the core layer, which also has some area to rotate and deflect, and then much more padding inside of it to try to limit concussions. And then this is a mouthpiece that's being designed to try to alert coaches when they may have a concussion. It's Bluetooth activated, and it has these little sensors in it. So if you can measure the rotational and the impact force to possibly signal when someone's had a concussion, and perhaps the coaches on the sideline with an iPad can see it and then pull them out and examine them, because maybe the player doesn't realize that they potentially have a concussion or even a subconcussive event. So what does this mean for the future of sports? It looks kind of bleak when you think about all the things coming out and all the literature coming out, what's going to happen. And I really didn't like Concussion, the movie, but I like this. And if I can get back to this.
Close your eyes.
What do they want?
The NFL wants you to say you made it all up.
I made it up.
They're accusing you of fraud.
If you retract, you'll be fine. This all goes away.
Why are they doing this?
They're terrified of you. Bennett Amalu is going to war with a corporation that has 20 million people on a weekly basis craving their product, the same way they crave food. The NFL owns a day of the week, the same day the church used to own. Now it's theirs. They're very big.
So the NFL owns Sunday. Sports are good. Sorry, y'all. Sports are good. We know that. The benefits of exercise, organized sports, is very well supported. We don't want people to stop playing sports and getting along and playing on teams. And if you really look at it, your risk of a TBI is much greater outside of an organized sport activity. Riding a bike, riding in a car, running on a playground. But yet, when you talk to parents, their number one concern is concussion. And especially when you look at football and soccer. Those are the top. But you think about NFL, it's a $63 billion industry. It's not going away anytime soon. What's going to affect the NFL eventually is if parents and guardians or players themselves say, I'm not playing and I'm not doing it. That's what's going to affect the NFL if that ever happens. It's not going to go away. People are still going to play football. And overall, all of this research and all of this stuff that's coming out, as kind of scary as it sounds, it actually has helped us to make our sports safer for our student athletes. So it is, in the end, it's probably a good thing. We're protecting them. But we still have a lot of work to do. So I'm going to wrap up, but just as a reminder, concussion is TBI. It's a traumatic brain injury. It's complex. We don't understand it. People are diligently working on this, but we don't know exactly what it is to treat and to prevent someone from having worsening after effects from a concussion. And public awareness has greatly helped us progress this field, and that's going to continue to happen. Certainly TBI and CTE we know are linked, but we also need to be linking that to PTSD and treating our military, because PTSD is a real condition, but CTE and PTSD are somehow linked, and we need to be treating them respectively for that. And we definitely need validation with clinical biomarkers and risk factors so that we can better educate our players. This is what you've got. We're tracking your concussion. You've recovered. This is what we're looking at on imaging. And, and then actually giving them real advice. For a professional player, you might actually say, it's time to retire. We can see it. We can see it in your brain. We can see it in your markers. So with that, I'll wrap up, and I'll take any questions.
Even though things have obviously gotten safer, what about young children put into these positions?
Yeah.
Is
Like the Pop Warner football?
Yeah. Is there an increased risk, or because their brains are more plastic, is there actually a decreased risk for them?
So nobody knows. If you look at age studies, people will suspect that younger age, they can be more susceptible than people, but there's no data to support one way or the other. So it's really up in the air. And I think it's really about educating. I mean, I don't know that you need to have 7-year-olds out there playing football. I mean, come on. My son told me he wanted to play football, and I told him no. I was like, no. You're 7 years old. You can play football right now. So, their neck muscles are still underdeveloped. If you think about their cervical spine development, they're not normal. They're not at an adult level. So, I mean, it's probably, in my mind, it's safer to start at a later age. But there's nothing to support that.
one of the studies that it was highlighted, it's probably been about 15 years ago that was done, and it was a cohort study looking at single loss of consciousness and its effect on high school students' performance on the SAT, and showed there was a statistical decrease in the performance of those students who had only one loss of consciousness during sports play. And so I was going to basically get at the same question, which is, it seems in some ways we see neuroplasticity in kids that have TBI, that it's just remarkable they recover. Yeah. But in this sort of situation where it's a repetitive thing, it seems like they would be much more vulnerable, and that they're not little adults. They're
right. Yeah, they're not little adults. And you know, the issue that I have is that there's a lot of people that we don't know have concussions because they don't report it. And the other thing that really kind of worries me is all the subconcussive events, because that's I would imagine that's probably playing a role, but we just don't know. And how are we going to track that? People don't realize that something happened or they feel bad. How are we going to track that and find out that information?
In education, actually, concussion is now one of the issues that can be accommodated on a standardized exam. So if you have a hit, yes, if you can demonstrate that you have had TBI, you can receive accommodations for college testing.
Didn't know that. Good to know.
Dr. Notarianni, what are our resources for some of our patients who come back to clinic who are having some significant symptoms after concussion for neurocognitive testing?
Yeah, so, you know, there's not a concussion clinic here, although I've wanted to start one, but the resources we need are many, and that hasn't been successful. But I have seen a number of concussed patients in my own office, and I have the impact licensing software. So I'm happy to take care of those patients and see them and test them. And I've told every parent that comes in, if you want to come back at the beginning of the season, we can do one before you start playing and have a baseline. And so I've offered to do that, and it's, you know, it's just a short office visit. The test takes 20 minutes.
After your extensive review, and let's put you in the position of being director of the National Institutes of Health. How would you, where would your thrust be if you had the National Institutes of Health available to you to investigate this?
You know, I think at the very least in diagnosing it, so imaging and biomarkers, because I think that will allow us to get better treatments and possibly, you know, help our patients more than just, hey, don't go play for a week and then go back in. So, and I think that's where we need to start. And then I think that will help us greatly expand the field, because then if we can tailor our imaging a lot better and we can see it, it's a lot easier to take care of and to think of more ways to treat it. So that's what I would start with.
You had some very interesting data on cytokines and reaction to injury, but I didn't hear anything mentioned about neurotransmitters.
Yeah, I didn't see a lot about neurotransmitters. A lot of people are looking at the cytokines, and they're looking at the only neurotransmitters, like, you know, they're looking at like GFAP and S100, looking at blood-brain barrier disruption and things like that. But other than that, there hasn't been a lot looking at like glutamate or anything like that. Although we know glutamate's playing a role, so.
The old traditional ideas haven't improved a great deal. There's a generator somewhere deep in the brainstem, upper brainstem maybe, that alerts you to the cortex. Alert. Well, then you have to ask yourself, where does that input go into the cortex? There's 6 layers
right.
in the cortex. And input can be in the 4th layer, in the visual area, the stripe of Gennari, and it can be in other layers. And to define what's causing, what the physiology of consciousness is with newer techniques like we have here with imaging, I'd look at the as close as I could at the cortex for changes in well, any kind of activity, not blood flow, but neurotransmitters.
And so, yeah, and that's good. The problem is like most people who come with concussion, they don't want a brain biopsy, you know. They don't want a lumbar puncture. So you're talking about, so we're looking at serum markers right now. You know, a lot of people are focusing on serum markers, draw their blood. So. Oh, yeah.
But that does bring up another point that you mentioned about this is documented or proven only equals more. And sadly, we don't do autopsies like we did 30 years ago. There's an economic factor to that. The insurance companies won't pay for an autopsy. But
I think you can, if you're an athlete or even not an athlete, you can go to the CTE website and they actually, that foundation, I think you can log in and say, I want you to take my brain, and they'll, when you die, they'll take it. I think Sam had a question.
I enjoyed your talk. A quick question about apolipoprotein E as a risk factor. Can we do that as a study, like to draw basic levels or go from there?
Yeah, we may be able to. There's a bunch of there's probably 150 clinical trials right now for concussion. So we could look through, maybe we could tailor on to someone who's doing that. It's a good idea.
One last question, probably got a lot of parents in here, is you're right, football's not going away anytime soon, but we are community members, and what should we be doing? How should we engage to try to minimize the risk to our children and to our children's friends as responsible parents in addition to being physicians?
Yeah, that's a hard question because I get asked that almost every day in my office. Like, can they go do this? And I'm like, oh gosh, I don't know. What would you do if it was your child? I mean, I just told you, like my son told me he wanted to play football, and I told him no. And because he's 7, there's no need for that. You don't need to have that kind of contact right now. But I think really being a patient advocate and educating and making it not a stigma, because I think what happened was everyone said, well, you have a concussion, you're out, and like you really get isolated from your teammates and things like that. And so I think moving towards an active rehab is good and keeping them involved. But also making the students or the children aware that it's okay to report it, it's going to be fine, you're not going to be ostracized, and just educating other parents, because a lot of other parents either don't think it's real or don't think it's going to happen to their child. I think if you get the word out, if you have the time, being a little sideline, physician or something like that is always helpful. But I think, just recognition.
An inherent part of soccer is using the head.
Yes, and that's a huge investigation right now.
So are they looking at the difference between head injuries from the ball or head injuries from hitting someone's knee?
Yes. Yes, so people are looking at that. If you hit the ball, it's the same as hitting the ground or hitting somebody else. So far, nothing has proven one way or the other. So hitting the ball is worse or something like that. They're looking now into helmet gear for soccer players or eliminating heading the ball. So, but yeah, that's a very active topic, especially in female soccer. So.
Heading has been eliminated in youth soccer in this country since 2015, I think now,
yeah.
Right? So under 13, you're not allowed to head the ball anymore. So in youth soccer.